So the talk is on red cell blood transfusions. I'd like to acknowledge both the NIH and the Canadian Institute of Health Research for various bits of fundings. That leads on to the second part, which is not inconsequential. Investigators always have biases. My bias is obvious. I'm the PI of 2 of these trials, so I freely acknowledge that. But I will attempt to give you a neutral view as far as I can. So in the next 45 minutes, what I'd like to do is first of all walk us through, remind us really of what are the various proposed definitions of anemia in the newborn, to discuss clinical burden and effects. So this will largely be a physiological section. Docs and medical people are great, particularly in the neonatal intensive care unit, at using physiology to substantiate their arguments for what they do to babies. Anyone can make up a physiological argument almost for any strand of thinking. So we'll look at these, and because also in medicine nothing comes free of charge, everything has a cost, there's a risk-benefit ratio attached to everything, we'll try and look at the pros and the cons. The shortest section will be an attempt to reduce transfusions. If, as I'm going to argue to you in the next 40 minutes now, that we really don't know what we're doing when we transfuse, then is there any way to reduce transfusions? And we'll briefly talk about placental transfusion. I certainly have no wish to recapitulate the excellent work that's been done for you by Dr. Anderson. I'm not going to sort of spend much time there. We'll talk about minimizing iatrogenic anemia, and we'll also briefly discuss erythropoietin, and that will lead us to what I think is the central issue. What are the randomized data that we can use? So, going back, and it's appropriate that we're in Scandinavia. So some of the early onset of work in the modern era of neonatology, if I can put it like that, was done actually in Scandinavia. Lundström, Saanen and Symes. Dahlman, I think that's a Scandinavian name, although he did his work in Boston. And they identified the following problem. Rapid developmental changes and complex interactions for oxygen prevent clear-cut transfusion. Consequently, clinical practices vary widely. And what you can see in the set of graphs with 5th and 95th centile is the ranges of hemoglobin here in grams per litre over a postnatal age on the x-axis. And you can see that both the nadir is very low, but you can also see the range is quite substantial. But of course that was in the late 70s and 80s. We're surely so much better now. This was an international survey we did asking tertiary care neonatologists just exactly when they would transfuse or not transfuse in a questionnaire. Over 1,000 in something like, I don't know, 15, 20 countries, it's a bit of time ago, were asked, when would you transfuse this 1,000 grammer, who is either on no support and an increasing scale of respiratory support right the way up to mechanical ventilation, and either in the first week of life or down to the 4th week of life. And I think you can see that the median and interquartile ranges are really quite high. I guess with this you can all hear me at the back, can you? My voice has had a bit of laryngitis recently. So you can see that the range is high, as you would expect, falls, but this range is really quite worrying. I won't go through the exercise of asking the audience now when you would transfuse an infant, but I would warrant that even though this study was done in 2012, practices would vary quite as much. So when practices vary, I mean, I guess the issue is why do they vary? But I think one core component is that we don't know what the, quotes, right thing to do is. So what is the risk-benefit ratio of transfusions? You could postulate that a higher hemoglobin may improve oxygen transport, or it may improve cardiac output. Older literature you'll find, I'm thinking particularly of the seminal articles by Stockman and Oski, talk about increase in weight gain. I won't discuss that. I'll tell you quite definitely that that doesn't happen. You don't get weight gain if you transfuse. But it's still in the background thinking of many of our colleagues. Apnea we'll discuss. The flip side, in other words, the cost of transfusing more, is that it may increase infections, in particular donor-related infections. And iron stores. Of course, red cells contain iron, so iron plopped into the baby leads to excess of iron. Iron leads to all the alphabet disease soups of neonatology that you all know and that we can all recite and are the bane of our existence. In children and adult ICUs, death rates have been implicated, and now there's some data from the Brazilian units, large retrospective databases that suggest the same, so we'll look at that. And there's a lot of noise about so-called old blood, so we'll discuss that briefly. But if I were to ask most of you why you transfuse babies, a lot of you would most probably say it has something to do with improved oxygenation. This is now old data using near-infrared spectroscopy or NIRS. This comes from Holland, although there's a variety of such data purporting to show some changes, and we'll discuss those. Can I ask for a show of hands, who's using in their units NIRS? And what are you using it for? Think about that. Let me now just walk you through this slide. These are regional cerebral oxygen saturation. So one would think higher is better. That's the standard way of thinking. And this is not a randomized trial. So clinicians here are using their own practices and transfusing. If the pre-transfusion hemoglobin here, for instance, is 97 grams per litre, or up here between 97 to 113, or 113 to 129. And there are three triplets. There's triplets for each of those: pre-transfusion, post-transfusion, during transfusion. So you can see, if we take the most lowest hemoglobin, that there's quite a step upwards. So I suppose this must be good. We would hope it's good. But what I'm going to argue is that this is a surrogate outcome, and we don't really have good clinical correlates. Now, there are many in this audience who know a lot more. In particular, I'm looking at Gorm right there. But I'm going to argue that this is a surrogate outcome, and that we don't really know, given the buffer capacity of the infant hemoglobin, to unleash further oxygen in cases of hypoxemia, whether this is necessarily good or bad. And to buttress that, I'm going to argue that a good trial, relatively small, but good hypothesis-generating trial out of Denmark by this gentleman here in BMJ could find no clinical correlate to this finding, which was that when clinicians were aware of what the results of NIRS was, as opposed to being blinded to those results, they spent less time in the valleys and the mountains of oxygen. But although this did actually result in a theoretical lower oxygen burden, when one looks at either mortality or brain injury on head ultrasound, there was no benefit. Now, this was an underpowered study, but I think it does lead to some wondering what we would do with the cerebral oxygen saturation value. So I'm just going to park that. I'm sure that's controversial. I'm sure that some of you will attack me for being minimalistic on this. So what about cardiac function? So again, there's been a lot of interest in cardiac function. Every one of our units has young people with an echo probe at the tip of their finger. And essentially, for whatever ultrasound measure you look at, and these are 4 of them. This was probably the first paper that really put this on the map. Let's look at stroke volume. Again, a non-randomized study looking at what clinicians were using as their own transfusion cutoffs. This is now in hematocrit. I tend to think in hemoglobins, forgive me. These are hematocrits, less than 21, going up to greater than 27. And I think what you can see is that there's a red line for each of those. These are the putative normal ranges, the upper end of the normal ranges. And what we'll find is that stroke volume is lower the higher the hematocrit, which is at the pre-transfusion level. So this again must be a good thing, right? Perhaps it simply shows that the infant heart is a lot more adaptable than we give it credit for. And I'm not sure that I see any clinical meaning to this right now. I think you can see the line of argument that I'm trying to develop. Anemia. Anemia was one of the commonest triggers for giving transfusion. I'll tell you right now, I'll jump ahead a bit, and I'll tell you right now that the pooled data from Cochrane reviews of relatively small trials does not seem to show any benefit. However, there is a case to answer for anemia that we haven't quite sorted out. And this is from one of the kingdoms of apnea. It's from Cleveland and Richard Martin's group. And what you see here is epoch 1 being on a postnatal age on the x-axis in the early days, and on the y-axis is episodes of intermittent hypoxemia, defined as such, very similar to the definitions used by Christian Pertz and Barbara Schmidt in suggesting that many and long durations of intermittent hypoxemia have clinical relevance. And these episodes are low in epoch 1, jump in epoch 2, and stay high. So if that truly is a surrogate for clinically relevant events, as Barbara and Christian suggest in the JAMA paper, then reducing these would be of enormous benefit. And if I now take you to the bottom, more complicated plots, they're triplets here. This is in epoch 2, and what you see is a reduction in the number of intermittent hypoxemic events with a blood transfusion. It's not a huge reduction, you see. I'm not sure what that means. Here, in the nadir of intermittent hypoxemia, in other words, the lowest value to which that saturation will fall is down here and is jumping up in epoch 2 and epoch 3. I suggest that this sort of information needs to be carefully evaluated. I think we also need to think about what that type of information means when we're talking about how to generalize the results of the oxygen saturation trials. Not that I want to add to the controversy of the oxygen saturation trials, which are controversial as they are. Okay, those were the benefits. What are the putative harms? So, some of us in the audience with white hair, or any hair, might remember the epoch of transmission of HIV. And I count myself guilty for having transfused a baby and given that baby HIV. It was in '81 in Hospital for Sick Children in Toronto. That stage, the epidemic of HIV was just exploding, and we were basically totally blindsided. And that's the illustration for why we need to think about safety. So this is from the Queen of Transfusion Safety, Naomi Lubin in Washington. On the y-axis is placed risk. So it starts off high, 1 in 100 transfusions. I think you would all agree with me that's unacceptably high of a risk to transfuse. This is now 1 in 10 million. You may agree with me that that's probably an acceptable risk. And along the x-axis is the passage of time and the ingress of new diagnostic techniques, various antibody testings and stuff, to make the transfused blood as safe as possible. And you can see that both for the hepatitis and for HIV, it drops pretty remarkably. I think that that's quite an accomplishment. And one might draw the conclusion that giving blood transfusions and that risk is relatively acceptable. I think we should be careful. We don't need to be blasé. We should not be blasé. But for instance, the new various viruses around, Nile Valley virus, Zika, all have been demonstrated to be transmitted by transfusions. Moreover, there are all these exotica that have always existed, like Chagas, malaria, etc., etc. They may not be exoticas in some of your countries, but in the countries I've practiced, they're exotica. And you need to know where the source of your blood is. So I've been privileged to work in systems where we have no paid volunteers for blood donation. I don't know the blood transfusion system in most of your countries. In Scandinavia and Europe, I know it's a volunteer basis in most parts of the world. This is in the US, that well-known first world country, where people are forced to sell blood in order to get some money. So you need to know your local practices. Okay, this is seminal work from the group in Hong Kong, led by P.C. Ng. And what this group did was to look at iron load. So iron load, as you know, is a potential oxygen donor and thus has been implicated in the range of diseases, BPD, NEC, retinopathy of prematurity, IVH. And they did a very simple study, an observational study of infants who died. Less than 1,000 grams birth weight, if I recall right. And they then looked at the total iron in the body. And I'll just draw your attention to the last line of liver iron. And if the infant had, in her lifetime, had a lot of blood, as defined by a cutoff of 100 mils, there was a fair whack load of iron. So that's a problem. Oops, don't know what happened there. I'm sorry, I've screwed up. Oh, it's gone. That's good. Now the Dutch pediatric ICUs followed the adult ICUs in trying to say that a lot of deaths in the ICU were related to blood transfusions. And this is quite interesting work. I think it set a trend of thinking that we need to consider. On the x-axis, this was a network of all Dutch pediatric ICUs. So on the x-axis is something called the probability of death. It's sometimes called the LOD score in children. You may think of something like an Apache score in adult ICUs, which you may have heard of, or the SNAP score, etc., in babies. What they found on the y-axis is the mortality ratio, and for children admitted to a PICU who had a low probability of death, there appeared to be a higher death rate. That's concerning information. And it was followed up very quickly by the Brazilian network. I mentioned that earlier. Nowadays, of course, with large observational databases, you just cream off data and you crunch the numbers and you've got the answer. Or have you? This is the days of hospital stay. Infants less than 1,500 grams birth weight. Y-axis is cumulative hazard rate. And you can see it shoots up for transfuse. So transfusion kills babies. No? Well, you're right to be hesitant. This is a classic example of what was shown to us by William Silverman. How many of you in the audience have read William Silverman's book on RetroLittenFire aplasia? Mainly the older people, I should say. I strongly recommend, if there's one thing you remember from my talk, it's please just get a hold of his book. It's free on the web. I mean, you can go to Amazon. I have no idea how much it costs, but it's well out of print. But it's all free on that website. And it's like a detective story, but it's also like an epidemiology textbook. It teaches you an awful lot about what we still tragically haven't internalized often. So what this shows is the first depiction of an association that led us into a spurious pathway in neonatology. This x-axis is years from 1938 to 1946. Oh, and by the way, I just remembered his date of birth was 1917. It wasn't 1942. So he was quite an old chap when he died. So the black solid line is the rate of what we now call ROP. And you will see some accompanying lines of oxygen, iron, and vitamins which were being used in the Boston lying-in system at the same time, all exploding around the time that people were more interested and anxious to keep small babies alive. Unfortunately, as you know, people plumped for the wrong thing, and that may not have been a major problem, but it certainly distracted us from research for some time. So we're still doing this sort of thing, and there's a link to transfusions, if you'll bear with me, because the link is, do transfusions cause NEC? Let me ask the audience, how many of the audience withhold feeds during transfusions? Okay, quite a number of you. And I'm assuming that you do that because you believe in the entity of transfusion-associated NEC, or TRANEC. So this is an example of where randomized data is in marked variance to data from observational studies. So this is the relatively low numbers. So this is about 600 babies. You can't see that. There's about 600 babies accumulated. These 600 babies were randomized to either a high threshold to get hemoglobin or a low threshold to get hemoglobin. So that gives you an opportunity to examine anemia as being associated with transfusion, or, to put it another way, anemia precipitating a transfusion to give you necrotizing enterocolitis. And what this shows you is that there's a diamond. You can see the diamond just overlaps, and the event rate is, or rather the risk ratio is 1.62, but the lower 5% confidence interval is 0.83, and it favors liberal. The interpretation being that the higher the hemoglobin was, and therefore the more transfusions the baby got, that's a little bit of a stretch, but we can show that in additional slides, has less necrotizing enterocolitis. Now, observational studies, as I said before, you cream off from databases, and we routinely are doing that. These are now something like 30,000 babies. Huge numbers of data. So this must be the right answer, right? And you'll see that now that diamond favors restrictive, exactly the opposite of what the randomized evaluations showed you. And the other thing you see is an odds ratio of 7.5. You know, in medicine, and perhaps particularly in neonatal medicine, if we leave aside the innovation of mechanical ventilation, we do not have such a wonderful effect size from our therapies. In medicine, you don't generally. It's just a fact. So if you see an odds ratio of that level, you've got to hit the query button. You've got to say, pause. Can this be right? And you know, those were all retrospective studies. I don't know if Ravi's going to talk about this in his talk, but Ravi Patel did a very sound prospective study, because by the time this was going on, there was quite a ding-dong going on in the transfusion community anyway. And some of us were arguing that actually what was happening was that there had been a reaction. We had at one stage in the HIV period been over-transfusing, and now what we were doing was trying to come down. We were arguing that perhaps you don't need those transfusions. And some of us in the community really nosedived and came down really low. And then you transfuse, and you get what the adults are quite familiar with, a reperfusion injury. A reperfusion injury with local oxidation damage. And actually, Ravi set out to test that, not perhaps directly in those words, but what he did was to set a predefined level and look very carefully for whether the infant had had a severe anemia in a given week prior to the transfusion. And lo and behold, he found a high health hazard ratio. So the story's not unraveled yet. I'm hoping that we will be able to put that one to rest. After a lot of discussion in the Pennsylvania group, certainly in the CHOP hospitals, so the Children's Hospital of Philadelphia group of hospitals, we don't routinely withhold feeds during transfusion. Red blood cells are just beautiful. When they're normal, they are just beautiful. You take them out, you store them, you stuff some chemicals around them to keep them perhaps better for your transfusion, and they turn up looking like that. Now, I've stacked the deck here because this is a black and white photograph, but I just couldn't find a decent coloured picture of these schistocytes. But the adult units have been trying hard to use fresh blood. And I would warrant that some of us in this room who have neonatal cardiac surgeons, some of those units are probably using fresh blood, insisting on using fresh blood. Certainly in my unit or my ex-unit, that's what we were using. And they wouldn't accept that there was no benefit to standard blood. There's a cost, a major cost. First of all, if you reject some donors, and the donors get to know about it simply because it hasn't been used in time, you have an effect on your volunteer pool. I mean, these are people giving of themselves in a giving manner. That's a tautology, but you know what I mean. And secondly, it's got an economic cost because of the economics of taking the blood, storing it, and then you don't use it, you discard it. So these guys in Ottawa did the APERI trial, and this is the arm of fresh blood, and on the x-axis is age of blood, and the age of blood goes right the way up to 41. There's obviously a small co-intervention, you can see that here, because there's, or a confounding, because there's an overlap. But nonetheless, they did that study, and when they looked at the composite primary outcome of NEC, IVH, severe IVH, ROP, and BPD, and death, there was no difference. So if you still have haematologists in your vicinity who are arguing that your baby should get fresh blood, you may perhaps be able to persuade them otherwise. Let's very quickly move on to reducing transfusions. So I'm not going to tread on your ground. I'm going to make 2 points. When the WHO moved on the basis of Indian data and data from Mexico City by Chaparro on an excellent randomized trial on the basis of long-term iron stores for babies for full term, arguing for delayed cord clamping, that decision was unmistakably correct for neurocognition. When the AAP, the American Academy of Pediatrics, and the American College of Obstetrics moved on the basis of Heike Rabi's Cochrane to saying that preterm babies should be getting delayed cord clamping, that was jumping the gun. The data wasn't in, and they were in a problem because the largest trial, the trial out of Australia of about 1,600 babies, was in play. They were in danger of sabotaging that trial. Luckily, that trial didn't die. And contrary to Heike Rabi's data, there was no reduction in IVH. but there was a pooled reduction of all of the babies now available, 2,800 in death. So invariably, it's a good thing to do. About 25 to 35% of those babies in those trials did not, however, get the placental transfusion because they needed resuscitation. A new generation of trials will be looking after that. This is data from Iowa, and essentially this is a plea to all of us not to behave like leeches, and not to take lots of blood, and not to do thousands of tests without having a clue what we're going to do with the test results. This is 100% of what the laboratory wanted for various tests. And you can see that the generous neonatal staff liberally donated much more blood than the lab needed. Early erythropoietin. Who in this audience is using early EPO for the reasons of preventing transfusion needs? A minority. It has an effect. You can see that here in about 900 babies, and does drop the relative risk, but actually the fractional improvement is relatively low in numbers of units. And what's even more important than that is the exposure to donors. That was not reduced, as far as we know, because we don't have all of that data, because these were lots of trials. However, it also has an effect on increasing retinopathy, and the biology of this was worked out by Lois Smith in Boston. And if you look at prenatal oxygen, the vessels are growing towards the front of the eye, and there's a VEGF-rich area. You clamp the cord, you stuff some oxygen in, postnatal oxygen goes up, VEGF is suppressed, those vessels stop growing. But that hypoxemia develops at the edge of the vessels by about 30 weeks. VEGF is stimulated, VEGF goes up. EPO is very similar to VEGF and its action, so you can understand the biology. So now in the last while, which is appropriate, because really there's not all that much data, but what I'm going to now try and move to is telling you why new trials are needed and where we are in the new trials. We'll look at the randomized trial data. There are really two substantive trials to consider. The Iowa trial and the PINT trial. PINT stands for Prematures in Need of Transfusion, a title that came easily to somebody raised in England. One had actually, in the Iowa trial, had larger birth weights and was a single site. The other was a multicenter trial. The peacock question for Iowa was, in babies who are less than 32 grams, will the outcome of the number of red cell transfusions be diminished? I've already told you that the important thing is number of donor exposures, not the number of transfusions, by 36 weeks. They were statistically successful and showed a benefit in reduction, as you can see in the low versus high hemoglobin, but they had no reduction in donor exposure. They went on, as one should do, to plumb their data, and after a little bit of jiggery-pokery, came up with a composite of IVH grade 4 or periventricular leukomalacia in 0 out of 50 in the liberal arm versus 6 out of restrictive transfusion. They found some post-hoc difference. Meanwhile, we had been doing another trial, and I want to thank this group of investigators, including Robin White and Chad Anderson, and we wanted to look at smaller babies, and we wanted to look at a more clinically robust outcome, which we did a composite of intact survival. We can talk about composite outcomes if you want, but we thought that this was a bit better. We were very anxious to get at these babies early so that there was no contamination by other transfusions. And this is the sort of structure we built. This is the intervention algorithm. Week 1 down to week 3, all of them get lower as reflecting clinical standard care. And also reflecting clinical standard care was the need for or not of respiratory support. So yes, no. Within each of those, randomized into subset high versus low. And this is in grams per litre. I don't know what you use. Most people use decigrams per litre, so 13.5. The contrast is between a potential high of 135 to 75. We can discuss how we arrived at that algorithm if you wish. The primary outcome we suggested was death or bronchopulmonary dysplasia at 36 weeks, or severe surgical rot, or severe brain injury on head ultrasound by the worst head ultrasound by 36 weeks, echo densities, periventricular leukomalacia, expanded CSF space, and regrettably no difference. Now I had started this study because I got fed up of interminable arguments on ward rounds as to when we should transfuse babies. Nobody seemed to have an answer, so I thought perhaps I should actually do some work. Thankfully, although this didn't provide an answer, we had enough sense to do long-term outcomes. We went back to the Canadian Institute of Health Research and asked for a 2-year outcome. This was the composite of death, cerebral palsy, 2 standard deviations below the mean at a Bailey at 2 years, blindness or deafness. And you can see that composite I've ringed, and that p-value is 0.09. Obviously we're educated up to the point where we realize that what we need is a p-value of 0.05, but statisticians behave differently. Statisticians said, this is an interesting p-value. And when they said that, and they looked at the cognitive delay less than 70, they got even more excited. That's 0.06. So we did a post-hoc analysis, and we argued that while 2 standard deviations below a Bailey was very important, it was probably, and the developmentologists in the audience, you can correct me if I'm wrong, but we thought that looking for 1 standard deviation made a lot of sense both to the family, to the child, and to society. And now we find that that's statistically significant. So what do we do with this? Do we know when to transfuse or not? Well, of course, this is a post-hoc evaluation. And so we need to go further. In the interest of time, I'll skip over that and that. So we went on to get funding and managed to convince the Blood Institute of the NIH and the NICHD to do the transfusion for prematurity trial. In the meantime, my colleagues in Germany, in Ulm, led by Axel Frank, led the similar trial, basically on the same model of the PINT study, that, I think it's 1,200 babies, that closed. They are still not reported finally, and ultimately we'll do an individual patient meta-analysis pooling these data. Our data for a primary outcome of 1 standard deviation at 2 years of life on a Bailey is 1,800 babies. We've completed the enrollment. We've got about 6 months to go before we get the final follow-up. So my conclusion, my friends, is that low thresholds of PINT and Iowa studies were comparable. It's reasonable to maintain infants above those lower thresholds. The high threshold did differ a little bit, and we can discuss that. There's some issues about how you pick your algorithms. The benefit of higher thresholds seems uncertain. I'd suggest it's beginning to look like transfusion-associated NEC is not a true entity. We'll see where the data lies. I thank you for your attention.